İrem kapıyı çeksene. Sonrasında bunu. Hello, everyone. It's a great honor to be with you in that virtual meeting. It's Dr. Emel Ceylan Günay from İstinye University and Ulus Liv Hospital. I'll make a brief introduction to our topic. As it has been announced previously, our topic is about the innovative targeted treatment options for liver tumors, which we will discuss from the point of view of the international interventional radiology and nuclear medicine. Our session will last about 1 hour. In our presentation, we will talk about the innovative targeted treatment options for liver tumors, pre-treatment procedures, patient selection, and we will talk about what we do in our clinics. Modern therapeutic approaches in oncology includes targeted therapies of tumor tissues. Intra-arterial treatment of liver tumors are among them. And our mission is excellence in oncological care and diagnosis and treatments. On the basis of that mission, multidisciplinary scientific approach, experienced clinicians, technological investment and collaborative work culture is very important. On that basis, I find myself very lucky to work with in that hospital and work with such a talented interventional radiologist, Dr. Uçar, who will present intra-arterial access planning and processes for liver tumors, including different treatment options in interventional radiology. I invite Dr. Uçar for his presentation, then I'll do the second speech. Now I invite Dr. Uçar.
Hello, everyone. It's Dr. Uçar. I am responsible for radiology department at Liv Hospital, also İstinye University radiology department. I want to talk about with you radioembolization and other local treatment of liver cancers. Each year, it's increasing amount of liver cancer. We can see primary and secondary type of liver cancers, and main potential curative modality is surgery, either primary and secondary liver cancers, but less than 20 of patients are suitable for resection due to tumor size, location, inadequate hepatic reserve, and presence of extrahepatic metastasis. We have local treatment options. These are thermal ablations, transarterial chemoembolization, and radioembolization. There are a number of ablation methods. Heat's called electricity, chemical. We use mainly heat-based tumor ablation techniques. If liver is very good place to this technique, we use image guidance. We placed a thermal applicator inside the tumor, and we placed thermal applicator inside the tumor, and we generate electromagnetic energy, and it makes molecule friction, and it causes heat, and in a certain time it makes tissue destruction. When the ablation is done, we make imaging. Always we see a post-ablation zone larger than actual tumor size. We do thermal ablation in CT room under deep sedation and sterile preparation. We use both CT and ultrasound guidance. There are some examples here. 88 years old lady, elevated AFP, no obvious chronic liver disease. We can see first picture on the first line. Patient didn't want to go to surgery at that time because it's actually easy to operate. It's border of liver capsule, and its diameter is around 4 centimeter. It's actually beyond our limits, but she didn't want to go to surgery at that time. We make thermal ablation method with RFA. Second line pictures show that it's larger ablation zone than actual tumor size here. A week later, patient developed acalculous cholecystitis, and we did percutaneous cholecystoscopy at that time. And later patient all okay, and we follow up that patient up to 2 years. This is 2T axial imaging. There is no residual tumor or relapsing tumor, and we can see shrinkage of the tumor, shrinkage of the post-ablation zone. Here, T2 images and coronal T2 images, second line images. One more ablation example here. A 54-year-old man, renal cell carcinoma patient. Patient has developed only 2 metastases. One of them on the humerus, and the other one is on the liver. The liver metastasis is next to the duodenum segment 2, and we decided to make enough distance to metastasis between metastasis and duodenum. We make a hydrodissection here, and we did RFA, Here, post-ablation control imaging, T2, there is no residual tumor tissue, and diffusion weighted imaging, no relapsing tumor here. A year later, there is no functional living tumor here on the PET images. We can move on to intra-arterial treatment. The liver has unique blood supply, hepatic artery and portal vein. A normal hepatocyte and other liver tissues mainly get the blood supply from the portal vein, and metastasis and primary tumors get blood supply from the main hepatic artery. If we inject in the hepatic artery microspheres, it goes and spread all over the liver homogeneously. If we have any kind of hypervascular tumor on the liver, spheres mostly collected on the hypervascular tumor. In 1977, Dr. Yamada described transarterial chemoembolization, and it means embolization and chemotherapy. They use oily contrast medium. It called lipiodol. They mixture with chemotherapeutic drug and lipiodol. If we send that mixture, lipiodol can carry chemotherapeutic agent to tumor. We can see here hypervascular large HCC on the right lobe. There are very tumoral vasculature here, and the last picture we sent that mixture, lipiodol and chemotherapeutic drug mixture, and also there is no tumoral vascularity here. There is newer material to make a transarterial chemoembolization. We call it drug-eluting beads. It's like a sponge, but it's spheres. We inject chemotherapeutic drugs inside that material. It absorbs almost all of chemotherapeutic, and we inject hepatic artery to the tumor. It sits tumoral vasculature system, and it releases slowly, and as a result of this, there is high rate of effectiveness and a low rate of adverse reaction. There is an example here, 66 years old man, a hepatocellular carcinoma, multicentric located. We decided two-stage bilobar therapy. We start with right lobar chemoembolization. We make hepatic angiography. We can see in the central large hypervascular tumor here, and after TACE procedure, there is no hypervascular thing, and there is no tumor vasculature. Second line, dynamic contrast enhanced MR images. We poorly see the tumor border. And the next images, we see there is no contrast enhanced tumor part. It means almost all tumor tissues dead right now. We can talk about radioembolization next. To selectively target a very high dose to all tumors within the liver, regardless of their origin or location, while at the same time maintaining a low dose to the normal tissue. Infusion via a hepatic artery using differential blood supply to the liver tumors, preferentially targeting tumors. We use Y90 on radioembolization procedure. It's pure beta radiation. It's penetrate 2.5 millimeter and a maximum 10 millimeter penetration. Sphere diameter is 15 to 35. It's two-stage outpatient process. First, preparation and mapping stage. Second, treatment stage. 1-2 weeks prior to actual treatment, all patient undergoes a routine preparatory angiography because we want to assess individual hepatic vascular anatomy, and we want to embolize if it is there parasitized extrahepatic arteries, and also want to perform test injection of the technetium 99 MAA to screen for extrahepatic activity and determine the hepatopulmonary shunt fraction. We do in angiography suite, we use local anesthesia only. We use sedation if patient needed. You can see here often people use arterial puncture. We use usually almost all cases common femoral artery. We place the plastic sheet and then we place a plastic tube to femoral artery, from the femoral artery to the hepatic artery, and we use microcatheter to selective angiography and selective injection. For angiography, our main drawbacks is our contrast media allergy and kidney function impairment. Due to close proximity of hepatica and enteric vessel branches, many anatomical variants may occur, and an increased risk for non-target embolization of GI tract because of stress and reflux during the treatment. There are lots of variation of the hepatic artery. On the first picture, it's a very standard one, and often we encounter this variation. It's come from celiac artery, a common hepatic artery, and arising from left and right hepatic artery from the common hepatic artery. Type 2 is also often left hepatic artery coming from the left gastric artery. Here are examples. There is right hepatic artery coming from the SMA We call it replaced right hepatic artery. And also next one is coming from the left gastric artery, left replaced hepatic artery. Always we show that celiac and SMA imaging, and we have to explore any vessel to the liver, and also we have to explore portal vein patency. This is the last image here. We can see that portal vein is still patent. On celiac imaging, we can see left hepatic artery and right anterior right hepatic artery anterior division. It's very close. It's close as 1 centimeter. We have to, if we do right lobar treatment, we have to divide right anterior and right posterior sector dose. This image, we can see the on the right lobe hypervascular metastatic lesions. In the beginning, this treatment almost more than 10 years ago, we did almost all gastroduodenal embolization, like this picture. Right now, we do embolization less than 5%. And it's important to place to the tip of microcatheter at the same level, either preparation angiography and actual treatment stage. It's very important thing. For actual treatment, the tip of microcatheter was placed at least 1.5 centimeter distal to the last enteric vessel branch to minimize the risk of reflux. Those non-target embolization of Y90 microspheres to the GI tract. Last image for me, this is the before after pictures. Patient has mid 80s, colon cancer and very large right lobe metastasis, and after Y90 treatment, 3 months control, complete functional response here. Okay, I'm done.
Hello again. Now it's my turn again. Intra-arterial radionuclide therapy for liver tumors is our next speech. What we will talk about now is, first of all, what is microsphere treatment and basis of patient selection, radiopharmaceutical applications, side effects, and I'll give some of the examples of our patients and share their results. While treating cancer, what is important is in oncology, it has always been strived to find out more powerful therapies, combinations or dosing that can maximize the effectiveness while minimizing the side effects or give less harm to normal tissues. Why radiation? Radiation is used to kill cancer cells, a programmed cell death, and shrink tumors by damaging the DNA of the cells. The ultimate treatment goal is to maximize dose to tumor while limiting the toxicity. When we compare the external versus internal radiation, here is the range of external beam radiation. While using internal radiation, the hepatic radiation tolerance increases and we can reach to higher tumor doses with internal approach. When tumor dose increases more than 200 gray, it is related to improved survival outcome with an observed acceptable liver tolerance. The theoretical basis of treatment depends the different blood supply of the normal liver and the liver tumors. The normal liver is supplied predominantly by the portal vein. In patients with overt hepatic tumors, a higher proportion of liver blood flow is derived from the hepatic artery. The goal of radioembolization is to deliver radioactivity to the tumor via its arterial network. The therapy is based on the injection of microspheres with a diameter of 20 or 60 microns into the hepatic artery and their macroembolization of the tumoral vascular network. These are the tiny particles. When we compare it with a hair strand, this is a hair strand and this is the size of the particles. When we combine it with a radioactive agent, this is what it looks in real life, what we inject to the patients via intra-arterial route inside. The maximum penetration range of the agent that we use is approximately 1 centimeter. Its range is 2.5 millimeters around itself. When we compare particle sizes with the vessels, larger particles have more microembolic effects, while small particles permit deeper and deliver radioactivity deeply. The radioactive particles are injected through the hepatic artery into the tumor, while they become trapped at the precapillary level and emits internal radiation. In patient selection, our patient group are inoperable liver tumors, primary or secondary. In primary tumors, hepatocellular carcinoma or cholangiocarcinoma. And the other ones are metastatic liver tumors, which are basically colorectal and neuroendocrine tumors and other metastatic tumors as well. Multidisciplinary approach is very important, which we do in our clinics and decide the best treatment methods for the patients. That's an example of a patient selection for hepatocellular cancer. In intermediate stage here is the best preferred patient group, or advanced stage with low extrahepatic tumor burden is preferred. I'd like to take your attention to the 5-year survival rates here. While selecting a patient, the functional reserve of the liver and the life expectancy is important. What we don't want is extrahepatic leakage, hepatopulmonary shunt, which increases the dose which is given to the lungs. The criteria for patient selection starts with the laboratory tests. We want the bilirubin to be under 2, and we check the liver function tests. If albumin is greater than 3, it's good for us. If the tumor volume is lower than this 70% of the liver, and it's okay for us. But we don't want a cyst or hepatic insufficiency, or if the patient did not receive any external radiation therapy, it is okay for us. The process continues after blood tests and pre-treatment diagnostic procedures. Then a diagnostic angiography, hepatic artery perfusion scintigraphy is necessary. After that, the next step is the treatment step, radioembolization and post-treatment imaging. Then further blood test controls and to learn the treatment response, imaging procedures, which you can have an early response with FDG for about in 1 month. Hepatic artery perfusion scintigraphy and diagnostic angiography is mandatory because we calculate the lung shunt fraction and those calculations, and we see if there's any extrahepatic leakage and targets the liver lesions. It's a mapping, in fact, for us. Here are some examples of hepatic artery perfusion scintigraphy. These are 2 different patients, which here, one of them, there's a high uptake of the activity in the liver tumor. This is the other part of the right lobe of the liver, which there's a faint uptake in the normal liver tissue. And in the lungs, there is no uptake showing a lung shunt. But here, in the second patient, here, this is the liver tumor, but there is a diffuse lung uptake, as you see here. This is what we don't want to see in patients. If so, the treatment procedures are here, the SPECT-CT is preferred to see both anatomically and the distribution of the radiopharmaceutical. Here, as you see, the gallbladder, if we use the treatment before protecting the gallbladder, then there will be non-wanted side effects of the treatment. With SPECT-CT, we group patients if there is a perfect or good correlation between tumor lesions and radiopharmaceutical distribution, then it's okay for us to continue to the treatments. But if there's weak correlation between tumor lesions and the radiopharmaceutical distribution, then we do not continue with the treatment and decide other treatment options. That's a decision-making tree for treatment evaluation. Disease presentation and infusion options are some of the examples schematically. Here, there's a uninodular disease. Infusion into tumor is expected. And this is a segmental infusion where tumor and a little part of the segmental part of the liver is targeted. If there is lobar disease, then we have to give the treatment via main branch of the hepatic artery. And if there is bilobal disease, then sequential lobar infusion should be made, because we do not treat both of the lobes at the same time. There should be a timeline between the lobes. There are different dosimetric approach. This is what we use in our clinic. Liver mass and the lung shunt function is necessary for us to calculate the dose that we will give to the patients. Those may be adjusted based on the tumor vascularity, underlying liver performance, the performance status of the patient's pulmonary dose, and prior systemic therapy, which has a vascular impact. Extrahepatic complications are gastrointestinal or radiation pneumonitis, hepatic complications, which are radiation hepatitis and radiation-induced liver disease, which we never want to be come across. And the other one is radiation cholecystitis. Post-treatment adverse effects, most expected ones are flu-like symptoms, which can be managed with symptomatic treatments. The unexpected or unwanted adverse events are seen in a low rate. Now I'd like to show some of the images of the patients here. You see a patient with hepatocellular carcinoma whose tumor has a shrinkage after treatments. And this is one of our patients. The first, one day after the radioembolization process, after imaging after treatment, here you see the activity is mainly trapped at the tumoral site. And this is this patient's FDG scan after 45 days embolization. There is no tumoral uptake in the liver, an early response. And another example from literature, also a colorectal cancer with liver metastasis. We see an early response in 1 month here. This is before treatment and after treatment, which is associated with a long survival rates. This is one of our patients, which we did a super selective approach. This is the FDG scan FDG PET scan of the patient before treatments. Here is you see the liver tumor. And after the treatments, there's no uptake in the tumor site, full necrosis, and no harm to the normal liver of the patient. In another example, after 6 months after the therapy, the liver metastasis, you cannot see on the control images. The goal of the treatment is to maximize tumor dose while limiting the toxicity in right dose and right location. Transarterial radioembolization enables direct delivery of radioactive dose into a tumor via feeding vessels. So I want to remind my excellence, our mission was excellence in oncological care, which was closely related with experienced clinicians, multidisciplinary scientific approach, collaborative work culture, and technological investments. Thank you for listening me. If there's any gitti galiba, evet. Ama şu ekranı kaybettim. Okay, if there's As I see, there's no question. If you have any questions, if not, we're closing the session. Thank you for listening us.
Thank you.
Tamam.